Good afternoon and a very warm welcome to everyone joining us again on our Author Engage Coffee Room series. Before we begin today, I'd like to give you some information and some housekeeping rules to ensure for a smooth and trouble-free session. At this time, I'd like to inform all our guests that these sessions are being recorded and will be available on arthrex.com. And in addition, these sessions will be broadcast live on social media platforms such as youtube.com. Introducing our esteemed faculty for today. I've known these two guys for several years and worked closely with them in many different educational series that we've held. Two talented surgeons, and it's an absolute pleasure to welcome you both back to another session of Author Engage. Dr. Luke Cicchinelli joins us from the beautiful city of Vigo, Spain, where he currently applies his trade, treating patients with the best care for foot and ankle disorders. A developer of several different products and an internationally recognized faculty conducting lectures all over the world. With over 50 different publications to his name and involved in several humanitarian and civil work campaigns around the world, a fantastic guy and an even better surgeon. Our moderator for this afternoon is Dr. محمد Nassif, joining us today with an equally impressive background. Dr. Nassif comes from the bustling city of Cairo, Egypt, where he runs his successful private practice. And over the years, Dr. Nassif has gained a valuable experience from several internationally recognized institutions, including the famous Van Dyck Institute, where he did a foot and ankle fellowship at the University of Amsterdam. Dr. Nassif is today an internationally recognized foot and ankle surgeon and a member of several societies, including a committee member of ISICOS, CCOT, and AFAS. Welcome back to you both, and thank you for joining us. As you can see, this is our 9th session of the Author Engage series. That has been tremendous success in many of our medical education initiatives. We have 2 more sessions coming up in future, the glenohumeral instability on the 26th of May and ankle instability on the 27th. So please join us for that.
You go to something.
I'd like to now take this opportunity to thank all our healthcare professionals from around the globe for their courage and compassion during this time and helping us fight this global crisis. Before we move on to the main event, I'd like to just cover some housekeeping rules. As I mentioned before, please keep all your microphones muted at all times. This is in order to create a calm atmosphere and cut out any background noise. During the Q&A sessions for today, we'd like you to please submit your questions to authorengage@gmail.com if you're joining us from outside the Microsoft Teams network on the YouTube channel. And for those of you joining us on Microsoft Teams today, please submit your questions directly into the chat box. I'd like to now hand over to our faculty, our moderator for the session, Dr. Nassif, who will run through today's proceedings. Dr. Nassif, over to you.
Thank you, Mike. It's a great honor and pleasure, as usual, to be here. You said a few words about Luke, and believe me, you didn't do him half justice. He's a great guy and an even better surgeon, that's true. So today's session, we tried to change it a bit. You know, there are a lot of webinars going around, and maybe you can't even engage with all of them. Now, we tried not to make it like 2 simultaneous lectures or 2 consecutive lectures. So Luke would do his presentation, then I would talk about a few other cases or so. So what Dr. Luke thankfully did for us, he did a very comprehensive lecture on the Achilles, if you believe it, in 20 minutes from A to Z, as much as he could do. And because we are trying to make this an Ortho Engage webinar, so we want everyone to be engaged, what I will do is I will try to moderate a discussion after Dr. Luke's presentation and try to answer all the questions that you guys might have. What I would like you to do as participants is try to separate your questions into the following categories. So Achilles ruptures, acute or chronic, and keep those. So while Luke is giving his talk, try and keep these, start off with your Achilles rupture questions, follow that by the tendinopathy questions, insertional and then non-insertional. And at the end, even after we have finished discussing these, if you still have any other question related to either the acute or the tendinopathy, throw them out at us and we'll be happy to answer them as much as we can. So it will be Luke's presentation followed by a kind of discussion that we will try to gear towards these three topics as much as we can. So try and keep the questions, even if you have them during the Luke's talk, try and keep them coming out in this order. Now, as we said, this is really informal. We are trying to make this as engaging and as coffee room as we can. So we are here for you. Make the most of us, especially of Luke. Ask us all you want to know, and we'll try and answer all your questions as much as we can. So, Luke, I think the floor is yours.
Okay, thank you so much. And
Thanks, Luke.
Technology is wonderful when it works, and when it's not, it's a shame. But I appreciate the patience with everybody, because I really have tweaked this up until last night and early this morning. So let's get started. I really hope Nassif and I can share a wonderful cross-section of Achilles here with you all. So my idea with the talk was pictures and pearls. And again, as I said, what I really envision is us all sitting in the coffee area there in Munich with Christian and his team and all the wonderful courses, and basically just thumbing through our cell phones as is the custom nowadays for all of us, and just looking at pictures. And what I'd like to do is at the end of each subset, as you'll see as this lecture is laid out, is I have some things that I would encourage under each section and some things that I would discourage. So hopefully by the end of at least my segment of this session, that you'll have a good 20 kind of points and pearls for the whole talk, for both things that I would encourage us to do and things that I would discourage us from doing. So if we start with the anatomy and the biomechanics, which I love, it's really the basis of everything that we do in surgery. I think it's just worthwhile to remember, because everyone perhaps has different levels of involvement with foot and ankle surgery as a subspecialty. Some may be more generalist, may depend on your region, your country, and the certain patient subsets you receive. But it's always wise to remember that we're not just talking about the Achilles tendon. We're talking about the items or the anatomical structures around it, the retrocalcaneal bursa, the posterior subcutaneous calcaneal bursa, and even the fact that, for example, the gastrocnemius muscle has its origin proximal to the knee. So it actually crosses three joints: the knee joint, the ankle joint, and the subtalar joint. If we look at anatomy at a more vascular level, it's really important to always remember that the majority of the blood supply is coming from medially. And so let me see if I can get this. Let's see, let me change that to a color. 1 second. So let me take a second. And so just to remember, let me do that one more time. Just to remember that the majority of this blood supply is coming in medially here, okay? And then we see it on these kind of microangiovascular studies here, where the bulk of all the circulation, again, illustrated here in kind of a graph form, and then even up here with the dissection, that really this is all coming from medially. And so we have to be very, very careful with incision placements, with handling of the tissues in this area, and any sort of surgery on the back of the leg in the Achilles region and insertional area. This illustrates the importance of things such as no-touch techniques when operating, and certainly this is a very large dissection here, but for illustrative purposes, no touch. We have sutures retracting, so there's not a lot of heavy-handed retracting. Remembering the pertinent anatomy and the sural nerve and its substantial variability as it can cross the area. There's a lot of variations to the sural nerve at this level, and also more distal as we get into the foot, of course. And up in the upper right here, just the importance of the peritoneum. The peritoneum is fascinating, and I've pulled a couple slides out of the archives of my material and involvement with foot and ankle surgery that I'll show you shortly. But the peritoneum is just critical. And there's even been a study or so done over the years. I remember one from the 70s, believe it or not, looking through the literature, that demonstrated that you could basically dissect all the way around the Achilles tendon. In other words, dissect out the extravascular supply, and you would remove right there about 35% of the circulation to the Achilles tendon region. So that leaves 65% of the circulation, the vascularity of the Achilles tendon coming from the peritoneum, and so intimately involved with the Achilles tendon. So the incisions should really be placed in this area more medially. Stay off of the lateral side for sure, and central is not that great and medial is better. And then if we just get down to the actual tendon structure, thinking about the anatomy and the biomechanics and so forth, well, tendons are just really, really, really complex. Look at the multiple levels of fibers and collagen, right down to the cross-linking and the actual biochemistry of the collagen molecules and polypeptide chains. And so kind of from a very micro up to a slightly larger view of all the collagen fibers, we see that there's just incredibly complex and all these intimate layers of collagen fibrils. And so when something happens that is causing an issue for a patient, we have to look at what are those causes. There can be extrinsic factors, which perhaps we're able to control in combination with the patient. Then there's intrinsic factors, which may very well be to a large extent out of our control. Certainly age and systemic diseases and certain things like that, genetic predispositions, we're not going to be able to control very much. Body weight, of course, we could. But we get into the extrinsic risk factors, and these, when they all add up enough, lead into subclinical tendinopathy. And subclinical tendinopathy begins a whole nother pathway of very sort of biochemical changes and different hypotheses, and they all lead on to tendinopathy in our patients to have a symptomatic issue that brings them into the office. And essentially what we're getting into is, if we go into the old stress-strain curves, is we're starting off with a tendon that is basically somewhat relaxed, the crimped fibers, and as we get strain and we combine it on the graph with stress and we go through this, what we're basically getting into is, when we get into, let's say, longitudinal tears or tendinopathy or thickening of a tendon, that is prior to getting to rupture. So down here, okay, we're getting into supraphysiological loads on the tendon structures. The tendon's unable to withstand it, and we may not get a rupture, but then we'll get into, for example, non-insertional tendinopathy, where we get thickening and hypertrophy of the tendon. So all of this to me is very kind of fascinating to think of as a baseline. Again, this is the ABCs of Achilles pathology. And so I wanted to cover some of this, and even thinking about the gait cycle, because we need to always refresh ourselves within the gait cycle, what muscles are activated and functioning at certain times within the gait cycle, as that plays into not only the cause of the patient's symptoms, but also some of our efforts to treat them. And so if we wrap up my little tips and pearls for you with the anatomy and the biomechanics, I would just encourage us always to, with any patient, and this could very well be, and almost always is for myself, non-operatively and conservative care first. We need to try to strictly control as many of the extrinsic factors as we possibly can, training issues, types of shoes, the rage with zero drop shoes or even barefoot type shoes like 5-finger Vibram type shoes in different styles. I really believe there's a big role for dynamic imaging, both ultrasound so we can dynamically image the tendon under range of motion, and even thermography. I've seen some interesting work on thermography over the years, and I think it has something that should be investigated further or even brought more mainstream perhaps, looking at tendon changes as maybe a precursor for a tendinopathy. I know some work's been done that in the patellar tendon, which I don't treat, but nevertheless, I like to encourage gait and sport motion analysis as well. The logical question is, why is this patient having this problem? Is there a mechanical issue? Is it their gait? Do they have some sort of loss of flexibility, a weak gluteus medius muscle on one side, or some sort of sport-specific issue that is causing them to have Achilles tendonitis. My experience, for example, as we get into the next section here on mid-substance tendinopathy, is that it's usually unilateral. And it seems to me more that insertional tendinopathy of the Achilles is bilateral. So if it's unilateral more frequently in my clinical experience with non-insertional tendinopathy, well, why is that? Where's the biomechanical fault? So gait analysis, sport motion analysis specific to each patient's individual hobbies, for example. Careful evaluation of the influence of equinus deformity is very important. Is there a contracture? Is it a gastrocnemius contracture? Is it a gastrosoleus equinus, for example? The old silver skull test, testing these patients or evaluating them with the knee extended and the knee flexed. And I, in general, discourage immobilization for anything to do with the Achilles tendon. And we'll get into that more with the acute rupture and so forth. But I don't believe immobilization is really that great an idea. I would discourage us from immobilizing the Achilles tendon. Tendons want to move, and yes, we need to alter those extrinsic factors. But even a runner, for example, let's get them on a bicycle. Let's get them warming up on a bicycle or doing some non-impact loading and warming up the tendon before they get going. I also would discourage inpatients with rehabilitation type treatments and topical therapies. Topical therapies, I've found some of the compounding medicines can really work very well without running the risk of injection. Certainly, we don't want to inject around an Achilles tendon with a corticosteroid. But topical therapies can work. I think we need a little patience with them because they are topicals that will penetrate a very, very thin area. Superficial to the tendon. They will get in there. They also serve as a massage. And in general, I like to tell patients, a minimum of 6 weeks and a maximum of 12, or at least up to 12 weeks of physical therapy rehab to see how you're doing. I'd like to see a response by 6 weeks that continues to improve up to 12 weeks. Certainly, if there's been no response in 6 weeks, I tell them, well, let's just, take it from there. And then if at 12 weeks, I find most people have kind of maxed out, or if they're doing really well, then of course continue. And I don't think we should have any rush to operate in initial stages with Achilles tendinopathy, Achilles tendonitis. I think we should exhaust those conservative measures. Moving into the next subset of mid-substance tendinopathy, this is when we get into that thickening, fusiform thickening in this area of the Achilles tendon. We've all had these patients. You can see the classic MRI pictures here with a thickening, and this is non-insertional. This is up proximal to that. And here we can see a dissection. You can see the kind of injected or hyperemic peritoneum around this area. And this mid-substance tendinopathy really does respond fairly well with diligence, to eccentric stretching. And this was shown years ago, and I will stress again that eccentric stretching exercises are really kind of a good sort of gold standard of conservative non-operative measurement for mid-substance tendinopathy. It does take diligence. It takes several sets, perhaps 6 sets a day, up to 15 repetitions, doing it correctly and doing it diligently and being really compliant or insisting with the patients that they really give it a fair shake to see if we can get this to quiet down. I've had Achilles tendonitis myself over the years from running. I've never been keen on having any sort of surgery, so I really like to consider exhausting all these conservative measures with my patients as well. If we do get into patients that are non-responsive to these types of conservative measures, well, then, of course, we're getting into looking at the tendon here and going into longitudinal debridements, debulking of the tendon. You can see here taking out a trough, so to speak, a very devitalized and mucoid degenerative type tendon in the center, and then closing it up and just reinforcing here that even after closing all this, I just can't emphasize enough the importance of this peritoneum. I always try to preserve on the way in and then preserve and suture that peritoneum on the way out. So really, really important. Now, when getting into these cases of mid-substance tendinopathy, the logical question I always ask myself is, well, how can we leave it better than it was? And as I get into my tips and pearls, so to speak, I'll give you a few other, share a few other thoughts. But I always think it's wise in foot and ankle surgery to decide, well, how can we be leaving it better than it was to try to help or offset some of the biomechanical or supraphysiological forces that caused our patient to have the problem anyway. So FHL augmentation, the flexor hallucis longus, makes a tremendous amount of sense for these reasons here on the left, both the in-phase transfer, reality of it, the fact that its axis of contractile force is basically identical to the gastrosoleus Achilles tendon complex. It's certainly accessible. It's right there. And this has been utilized quite a bit and is highly recommended in these cases. I do like to share a case of courtesy of a colleague of mine and wonderful friend, Dave Caldarello in Providence, Rhode Island, where just demonstrating the dissection of debridement of this longitudinal mucoid degeneration and then accessing flexor hallucis longus here and harvesting it, but then getting ready for insertion. And the reason I like this technique, and credit to him again, is that he's inserting this medially. And I'll have some questions for Nassif later, and perhaps we can, focus on it a little bit in the question and answer session or the conversation as portion. But the footprint for Dave is actually where this K-wire is in the calcaneus and making this a medial pull, so changing the vector a little bit. So I've placed this myself dorsally in the superior aspect of the calcaneus. On occasion, I've put it directly into the back of the calcaneus. His preference is to put it in medially, so the vector of pull is more medially, and then to really anastomose it into the Achilles tendon there. And as we contrast this perhaps with Nassif's experience in his publication with the endoscopic flexor hallucis longus transfer, I think it would foster some good kind of fun questions and considerations. So if I wrap up my tips and pearls on the mid-substance tendinopathy for you all, I strongly encourage with mid-substance tendinopathy giving eccentric stretching and full complement of physical therapy modalities a fair shake. We have to encourage patients to modify the activities. Again, I find this is typically more unilateral in patients, and so I really want to kind of try to help them figure out what's causing this. Where's sort of the biomechanical fault? I do think it's wise to consider these minimally invasive techniques. I mean, none of us are that excited really to be making these big, long incisions, and we're all trying to get away from that and are moving away from that around the Achilles tendon. But there's some very interesting techniques out there, be it ultrasound-guided microdebridement, some of the radio frequency coblation type procedures, paratenectomies or paratenon releases when it's thickened or fibrotic or scarred down, fascial band releases. Amal Saxena in Palo Alto, California has published a very nice series in the last year or so on kind of a minimal incision type based, very minimal approach to just releasing kind of this band around that, almost that watershed area and a hair distally in the Achilles before it gets into the insertion on the calcaneus, and just releasing that. And very active patients and getting good results with that. Certainly flexor hallucis longus augmentation is encouraged to be considered in all these cases if they do require open debridement or the tendon is really degenerated. And I do think it's worthy to see if, maybe perhaps we can be debating a little bit or considering the ideal insertion point of the flexor hallucis longus. I would discourage us all from immobilizing again. I just don't think immobilization really helps for these patients, even though maybe it's kind of reflexive. We want to go there, just kind of put it at rest. But I think mobilization is really best under control. And I would discourage us ever from ignoring the importance of the paratenon. Really, I think the sun rises and sets on the paratenon around the Achilles tendon. Again, probably 65% of the circulation in that area, and really just critical. When there becomes fluid between the paratenon and the tendon, which you can see on ultrasound, for example, when there becomes scarring, this really becomes the pathway onto problems. I also would always discourage us from overselling expectations. Obviously, we all want to get all our patients better. We all, could potentially have these exact problems ourselves or have, and we want to always kind of coach the expectations for patients, be it non-operative management or surgical management. As we go into the insertional disorders, which is just funny, as I put the slide series together, I I tried to get about 5 or 6 slides for each section to keep it flowing and not bog us down too much in the spirit of time and so forth. But I found that my insertional disorder subset here, there's just no way to, not have a few more slides in there. I think it's really important to realize that the insertional disorders is kind of like my second slide in the whole lecture. It's not just the Achilles tendon. We have the retrocalcaneal bursa area. We have the supracalcaneal bursa area that can be inflamed. Of course, we have these big pump bumps on the back, or prominence or bulky posterior heels that can cause problems with shoe gear. And really what you start to see when you look at the MRIs on these, and I do typically get an MRI on these if I'm going to be deciding on surgery. I don't think every person needs an MRI when they come in with this problem, but if they fail conservative care and it's just not happening for them, and I'm going to be considering surgical intervention, I absolutely get an MRI. And we can see here that 2 MRIs can be very different. This one has some longitudinal tearing and quite a bit of inflammation. Of course, there are different sequences as well, but nevertheless, you see more interstitial or intratendinous degenerative type changes here. Here we see perhaps more inflammation, background Kagar's triangle and that retrocalcaneal bursal area. And then this is always a bit of a red flag to me when I see so much spurring in multiple origins or multiple points of origin on the plantar cortex, as well as the back of the heel. So one of the things I really like to do and share with you clinically is I really like to have patients pinpoint, and I'll even put a grid, or I'll palpate, or I'll even sketch it out with a skin scribe or a skin marking pen. And I want them to really tell me, so where does this hurt? So, ma'am, where does this really hurting you? And it's kind of funny, I'll have patients close their eyes. Of course, they're prone here, so they're not really seeing the back of their heel anyway, but they're quite variable, actually, patients, when you try to get them to pinpoint where does it hurt. Does it hurt up here? Does it hurt a little bit more up in this corner? Does it hurt a little bit more in this area? And so I'm quite careful. I'm very, very diligent, and I would encourage us all to be so, trying to pinpoint exactly where these patients have the most of their problems. And why is that? Because there's nothing worse than actually operating on somebody and only coming to find down the road that they're doing real well. The x-rays look great and so forth, but they say, but I still have this little area of pain in one certain spot versus the other. And this is an example of that. Here I am. This is a 16-year-old boy, who I'll tell you a little bit about here in a second, but here I am sketching out myself. And exactly where both there's some erythema, this is more of a classic Haglund's deformity, but exactly where this patient's pain is and where the irritation is and where the redness is. And again, it's a 16-year-old. And you also see that I have the foot dorsiflexed while I'm doing this, because I am always thinking about the gait cycle and the biomechanics and how these people function down the road when they resume all of their activities, perhaps 3 months or 4 months or even a year from now. I want to be sure that I took care of their problem with the most assurance for long term if possible. So I'm dorsiflexing here because I want to know kind of at that terminal stance point of the gait cycle when they're maximally dorsiflexed and just before heel off in the gait cycle, this is the time that this area is going to be maximally prominent. And there's another reason to do this, and that is this case I actually did purely under local anesthetic. And so once you inject local anesthetic, perhaps you insufflate the tissues here and you get a little bit of local edema from the injection. Sometimes you can lose your mark a little bit and lose sight of exactly where their maximal problem was. Now, I tell you, this is a 16-year-old, and interestingly enough, his whole story just sounded a little bit odd to me, and I ended up ordering a rheumatology panel on him. And lo and behold, he was HLA-BA 27, and so that was interesting to me because it really kind of was something odd about his clinical case. And sure enough, here you can see quite a bit of irregularity around his Haglund's deformity, which, is really technically, with the terminology, the superolateral corner. It's not an insertional Achilles spurring issue. And so I would always caution us to be wary. I did refer him off to rheumatology before I ever did any sort of surgery. And it's just an interesting case because only 16 years old, and the diagnosis was never made prior to this. So even doing just foot and ankle procedures and looking at these folks carefully, we can actually contribute quite a bit to their overall health by here picking up a systemic condition. And just showing here that with clean dissection here, and after resecting this area, and I do a very thorough resection here, and I also clean out the bursa. I do this openly to look also at the Achilles tendon to be sure there's no longitudinal tears. But with the tourniquet let down, see excellent bleeding here. This will heal right back there very well. And at the end, I'm palpating, I'm simulating this weight bearing that I did simulated weight bearing maximal dorsiflexion. I'm simulating it here again, and I am palpating. That's my two thumbs, and I want to be 100% sure before I ever start closing that I've got that maximally reduced. What I always like to say is we want to take a convexity and convert it to a concavity. If we get into the more traditional insertional spurring and not just Haglund's, certainly we see these spurs here, and they're completely medial to lateral in almost everybody, but they don't always hurt completely medial to lateral. So that goes back to that original diagram where I shared, where I actually want to mark and have them help me mark exactly where they hurt. So we're cleaning up the back of the heel here, certainly with a sagittal saw. This is a reciprocating rasp. Get that as nice and clean as possible. It's always important to consider right now as well the thickness of the tendon. There's tremendous thickening and degeneration in these most chronic cases. And as you'll see here, we start to thin this down. And when you thin this down to debulk it a bit, we'll often find intratendinous calcifications, and they're not always present on the x-rays. They may be simply cartilaginous and not fully calcified. So as we get into the considerations of reinsertion and reinforcing the insertion, I strongly discourage any of these metal type implants. I've gotten away from this years and years and years. I inherited this patient probably 20 years ago, and they had sinus tracts draining out here, and I was concerned about osteomyelitis, and of course the tendons over here. I had to tunnel in from the side. These were some old metallic ankles. This was never that great an idea. That was not my case, but it just, some of these things, metal on the back of the heel just doesn't go. My preference really is the speed bridge type construct where we're getting such a really nice full contact, double row reattachment of the Achilles tendon. And all of this has been studied, of course, but we just really get a nice, even full contact reinsertion of the Achilles tendon, which allows us to do what? Really advance the rehab. Advance these patients, even eliminate casting, get them right into boots, still protect them from weight bearing in my hands for 2 weeks, but really get them moving along due to the confidence in the strength of the repair. Wonderful confidence in the strength of the repair. That's really historically borrowed from shoulder surgery. Certainly in cases where there's lots of degeneration, I also am a fan of augmentation or reinforcement with the FHL transfer. So here's flexor hallucis longus going right into the back of the heel. Again, perhaps Nassif and I and us all out there in the listening community right now can be talking about where exactly is it best to insert this, or does it even matter clinically? Perhaps it doesn't matter at all. And so here's just a case of augmentation with flexor hallucis longus. One of the reasons I am such a fan of the Achilles speed bridge and the double row type construct, and even the screws such as biotenodesis and tendon reinsertion technology with the biotenodesis systems is it's so versatile. Here's a case that really the systems both saved the day for me. A very unique case of a lady who had osteoporosis. She fell, she avulsed both her Achilles, and I was able, with a combination of flexor hallucis longus transfer and Achilles speed bridge, I was able to do both of these at the same time and get her mobilized very quickly and really solve a bit of a challenging problem by the versatility of the implants. I do think there's a role for the Keck-and-Kelly or the Zadig osteotomy. They're basically the same thing. And perhaps a subtle difference would be the Keck-and-Kelly. It doesn't really penetrate the plantar cortex, and the Zadig does. But the idea here is actually just shifting the posterior calcaneus forward. I know there was a nice article out of, I believe, Madrid with a fairly good series. I think there was about 18 patients utilizing this. And I do think it is worthy of consideration. Perhaps in some circles it's considered just of historical significance, but I don't think it is. I think it can be considered in certain cases, but I would caution in cases where there's a lot of fragmentation in the insertional zone. You see lots of calcifications, flocculations, all sorts of fragmented exostoses. I would discourage from those calcaneal type osteotomies, because in my experience, these patients really need this full kind of resection of the area. And I also like to caution that we're just dealing with the heel here. Okay, this is 6 years down the road, a patient of mine from many, many years ago, and they were not symptomatic. They did not have return of symptoms, but there's an awful lot of irregularity, even though I had done one of these kind of complete excisions and debridements. And so we're still dealing with patients' intrinsic factors, back to one of those original slides, the early slides. And so it's never quite over until it's over. And so when I see a lot of these types of fragmented exostoses, I really believe they need a complete, full cleanup. So the tips and pearls for the insertional disorders, I do believe that extracorporeal shock wave merits strong consideration. There seems to be quite a bit of literature and success with that as a conservative measure. I would always advise us and encourage us to rule out the seronegative arthritides to be sure we don't have some sort of systemic cause for an inflammatory issue, a Reiter's syndrome, an ankylosing spondylitis, psoriatic arthritis, something causing enthesopathy, calcific tendinosis, calcific enthesopathy. I like to carefully map, again, I can't stress that enough, the actual focal points of the pain. And I think this merits some consideration. When we are doing the surgery and using perhaps the speed bridge or some other anchors for the reattachment, to be sure of equal tensioning of the anchors. There's some folks who will complain of what in some circles we've called sort of a deep, a fascial expansion type pain, both medially and laterally around anchors. And so I think equal tensioning of the anchors is a small but very important point to focus on intraoperatively. And then not only the FHL augmentation, which I've already discussed a few times, but I do believe lengthening of the gastrocnemius, or addressing any sort of gastroc soleus equinus in these insertional disorders, is well worthy of consideration as well. I am familiar or aware that there's at least 3 articles or so out there talking about a gastrocnemius and lengthening as an isolated procedure without even actually operating in the heel area. Now, I've never done that myself. I think that's interesting to consider further, and so I've got it on kind of my encourage to consider that column. I do discourage, personally, eccentric stretching for insertional disorders. I find it makes them worse. I just find patients don't do well with eccentric stretching when they have this kind of inflamed, calcific deposit, bulky, inflamed, painful back of the heel. I do think that you should have great caution, we all should, with calcaneal osteotomies if there's a lot of fragmentation of the exostosis at the insertional zone. And I will also say this again, be just careful. We need to really coach realistic expectations. These folks still have their underlying sort of intrinsic factors, maybe high BMI, maybe just their own biology, I like to call it. And so that we're not changing that just by operating on their heel. Hopefully we can be encouraging them to change as much of the extrinsic factors as possible and a few of those intrinsic factors if they can. If we get into the acute rupture world, well, these are slides from the archives. I haven't made this incision in a long, long time. This is an incision that you could be the modification of one of the mini open or percutaneous type approaches that perhaps intraoperatively needed further attention or needed to be open to see things a little more clearly. But I think the question really with acute ruptures is to cut or not to cut. And the options go all the way from non-operative and some of the large series of randomized multi-center clinical trial type studies like the Canadian study back in 2010 versus the open, mini open and percutaneous approaches. Really the question is open, percu, mini, or simply non-operative, to cut or not to cut? Well, it all boils down to performance. No matter what approach any surgeon chooses, and depending on their region and economics and tendencies and practice patterns and perhaps just standard of care or medical legal considerations or just availability of material and so forth, it all boils down, no matter which one of these that we choose, it all boils down to the fact that what we're trying to avoid is tendon lengthening, and performance ultimately depends on tendon lengthening. So we're trying to avoid tendon lengthening in the post-treatment phase, be it post-operative or simply a real protocolized rehabilitation program. And back to collagen, I do like the anatomy, and this is just, of course, the microanatomy or the histology, but in the controls, we just know that immobilization leads to collagen disorganization. So here's control, which shows wonderful organization. Here's a patient treated in an ambulatory fashion, and we can see that the ambulatory fashion, where the ambulatory treatment approximates the most the control. And if there was immobilization or suspended, well, this becomes very amorphous and disorganized and nonlinear. So what happens? So you can still, of course, get something to heal, but what it really needs is active rehabilitation. And so the shift, of course, there's a non-operative, but the shift, of course, if surgery is to be considered or entertained by a surgeon based on their preferences and tendencies, well, to go to minimal incisions, percutaneous approaches or mini open approaches, and trying to get rid of this kind of really what is a big strangulating approach to suture placement on the tendon and these long incisions, and getting in more into the percutaneous approaches and the mini open approaches and ending up just with a small incision like that. And more importantly, advancing the rehabilitation. I really can't stress enough. I just love these old pictures of ours and mine from slides and lectures, and also from where I trained in Atlanta, about the importance of the peritoneum and the knots. And you can really see here just how vascular that peritoneum is. And this is obviously an acute rupture case. But look right here, the deep fascia, the engorged peritoneum beneath it. And so preserving and respecting and repairing the peritoneum throughout any sort of intervention, whether it's minimally invasive or open, is just really, really critical for Achilles tendon ruptures. I also believe the knots are hugely important. The gift box technique here has been shown to double the strength of suture repairs here. And as well, the knots don't end up at the rupture site. So the knots with the gift box technique are remote to the rupture site versus other techniques where those knots are exactly at the rupture site. So what does that allow? Well, if there's any knot weakening, then certainly the knots are not where the actual tendon was weakest, and then also less irritation at the area of the rupture. So I really do like that. And I've pulled this from the archives. I went back to the vault, as I said. This is a case that we operated on when I was a resident. Dr. Rook was a surgeon, wonderful master surgeon, really, and wonderful teacher and educator to myself. And this was an old open approach to an Achilles tendon rupture. But I just put it in because I really love the pictures. I just wanted to share with you. Here, you can realize that the deep fascia is really a distinct layer from the peritoneum. And so if we look here, we're puncturing into an acute Achilles tendon rupture. We've got the hemostat here. We're picking up the deep fascia, and we're puncturing, and out comes the rupture, the mop ends of the rupture, right? Well, then you can actually see, if we make that incision through the deep fascia, look at this peritoneum. And I've just put this in here because it just shows just how important and how vascular that peritoneum is here. We don't get to see that much anymore because we don't do these big procedures that much anymore. And so you don't really have the opportunity to see as much of an engorged peritoneum like that. And we, had our medical illustrator back in the day draw nice pictures of this. And really, this is a very vascular peritendinous tube around the rupture site. So the peritoneum just can't be stressed enough. My preference nowadays is certainly the PARS type speed bridge approach. This is the PARS mid-substance speed bridge distally. And so this is all a minimally invasive type approach with fiber tape, the 1.3 fiber tapes, and locking sutures, allowing basically a bridging of the area, a bridging of the rupture site, and getting 6 strands across the rupture site, which we know from the hand literature is really the ideal number of strands across a tendon rupture site for strength without being too little and without being too much suture occupying the area. Then there's no knots in this area when it's the PARS to mid-substance speed bridge approach. And there are knots here when you do the PARS proximally, which is the percutaneous Achilles system. And you can also do the PARS distally. That leaves the knots in the middle. My preference is this, to not leave any knots there and actually bridge this area. I do think no matter what you do from non-operative care to operative care, be it mini open, percu, it's really all about early active rehabilitation. Early active rehabilitation, get these patients moving. I just shared with you from Jim McWilliams and Gordon McKay's paper in 2016, the post-operative rehab protocol, which even if you prefer non-operative management of these, the idea is get these patients weight-bearing, They don't need to be non-weight bearing that much. Physical therapy started very quickly, even by a week. We want resistive plantar flexion exercises around 2 weeks. We want to begin some low resistance cycling, but not allowing past dorsiflexion by a month, 6 weeks, or even sooner, depending on the patients, out of boots, and beginning really getting them back into progress to sport-specific activities by 12 weeks. And some patients are even doing really well by 4 months, 16 weeks out. Gordon, with his team a few years ago, published a very nice article. It was a case study, but it was a high-level elite athlete who was back running down the hill, pushing a bobsled in the Olympic trials at 16 weeks after surgery with the PARS Achilles speed bridge approach. Tips and pearls for the acute rupture: I encourage immediate weight-bearing and active functional rehab, whether it's non-operative or operative. I believe mini open and percutaneous approaches in very active patients under 40 years old are absolutely indicated, and literature supports that as well. I do think a very big key is the ability to put in locking stitches and have knotless type repairs to avoid irritation, both potential wound breakdown, but also irritation to the peritoneum, and repairing and completely respecting that peritoneum, I just think is critical. I discourage casting for greater than 2 weeks duration in anything. Even an Achilles rupture treated non-operatively, I would discourage casting for longer than 2 weeks. I believe maybe a plaster or fiberglass casting would be acceptable in a plantar flex position for 2 weeks, but even then, if the idea was complete non-operative management, then getting them immediately into boots with heel lifts and into that active rehabilitative type program, with a very strong protocol being followed. I don't think MRI routine use is necessary. I would discourage that for acute ruptures, and absolutely the no hand techniques no touch techniques and not being heavy-handed with retraction, I think is very, very important. I also would discourage large non-absorbable sutures. I think, Ethibond needs to kind of be retired. There's lower gauge sutures that at a 2.0 fiber wire suture, for example, is just as strong as a number 2 Ethibond type suture, and certainly there's other sutures, PDS and different types, that are less reactive, and we just need to avoid as much as possible large non-absorbable sutures and large prominent knots in these areas. If we now go into the neglected chronic rupture scenario, what we see, of course, is that we've got different considerations because it depends on the chronicity of the problem. We see that the MRIs may tell us different things about intertendinous degeneration. We may see big gaps. We may see gaps down in this area as well as up here. Upon dissection and getting into these, we may find something that we weren't quite convinced of by preoperative imaging here with this bulbous end retracted up here. And now we need to bridge this area somehow here with very, very diseased tendon in this area here. This is more of a subacute case, not quite so delayed like some of these other ones. Like a delayed case could be, of course, 6 or 9 months or a year later. And it also could be perhaps only a few months later. So what are the options to kind of gain some length there? Well, we always have to consider the options for gastrocnemius turn down, the aponeurosis type turn downs, gastroc type recessions, trying to gain some length, gastroc recession here, plus turn down, trying to bridge the gap. And then the use of the flexor hallucis longus tendon transfer, again, which we've talked about for the chronic insertional, well, also for the neglected ruptures. And then Nassif, I know, has an experience which is very interesting and published for even using it in the acute ruptures. But here I'd just like to show that one of the concepts, and I'd love to discuss it in the question and answer session with Nassif also, is one of the original concepts, of course, was that this can bring vascularity into the area of the diseased tendon. And here we are suturing the muscle belly actually into the tendon and hoping to improve the vascularity there because it is such a low-lying muscle belly. So I also wonder there, are we getting the same effect with depending on where we actually insert the flexor hallucis longus tendon into the calcaneus? depending on the different techniques that we've already talked about. So there's the flexor hallucis longus muscle belly, reinforcing that area. And then again, the options of the fixation with pull-out type techniques or tensioning in through the bottom of the heel. Again, here in the dorsal aspect of the calcaneus, and sometimes perhaps directly on the back, or even, as I showed, medially. And then don't forget about peroneus brevis. We've already discussed, of course, that flexor hallucis longus is more in vector, more in phase, but peroneus brevis has actually been used for years. I remember the original articles by Dr. Vincent Turcot. I believe it was in the Chicago area back in the 80s. And he was using peroneus brevis in primary repair of Achilles tendons, just like now some folks are using the flexor hallucis longus. But peroneus brevis can help. And this is a long harvest, okay? This is through making a separate incision, of course, into the lateral muscle compartment. This is going through into the lateral muscle compartment by making an ancillary incision here, but all through the posterior dissection. This obviously is the opposite, but this gives you more of a long harvest for peroneus brevis, whereas this gives you the similar type of harvest you would get with flexor hallucis longus. I also think that Dr. Mafuli and others, I recently read an article from Latin America, from South America. Others are proposing more of a minimally invasive type approach to chronic Achilles tendon ruptures. And let's face it, anything that we can do that will give this a similar functional result in a more minimally invasive fashion in the back of this area, and the Achilles, is certainly worthy of trying to do. And so if we go into my tips and pearls here of the neglected and chronic rupture, I would encourage us to get the most accurate estimation of any gap or tendon quality that we can preoperatively, and yet intraoperative decision-making always really applies. And I'll just go right here to one of my points on the discourage column, is that I would discourage us being set on only one approach when we're going into these types of neglected and chronic ruptures. We should have plan B and plan C, maybe even an allograft available, just because we're never quite sure with these neglected cases exactly what we'll find. I do think it's wise to consider gastrocnemius lengthenings or turn downs to try to get some length. Certainly, reconstruction with flexor hallucis longus tendon has been covered thoroughly here and under different subsets during the lecture. I do believe we should be embracing the evolving minimally invasive techniques and comparing them well functionally with the more traditional techniques. And I can't stress enough the importance of DVT prophylaxis. It's interesting if you look through the world literature of the incidence of DVT and PE related to foot and ankle surgery specifically, it could really easily come to the conclusion that it's just not warranted. And I just clinically myself have never been able to wrap my head around that, just sharing, here in this talk about the ABCs of Achilles. To me, I kind of live in fear of patients getting a DVT or a PE. I've had a patient pass away. I've had people get DVTs and PEs, and specific to what we're talking about today, which is Achilles tendon work. If you want to try to find at least some evidence that would support DVT prophylaxis on a routine basis in foot and ankle surgery as a subset, it would be Achilles ruptures and Achilles tendon acute or neglected ruptures. And why is that? Because it's basically knocked out that gastroc soleus pump, which is the main pump that helps us with venous return. So I do believe very strongly that we should be encouraging DVT and PE prophylaxis during Achilles tendon rupture surgery. Okay, I would discourage forgetting about peroneus brevis. It can help when necessary, and there's some reconstructive procedures even today where it's recommended. I know Dr. Mafuli has published on that, and I do believe it goes back to our patients. Some athletes may have more need for their flexor hallucis longus versus their peroneus brevis in a mechanical or biomechanical sense. I'll wrap up here with just the last two sections, which are the shortest sections, but I wanted to put in just a few comments on equinus contracture and the fact that I think we sometimes either overdo it or don't give it enough attention. I think it gets too much love or not enough love. And there's certainly different approaches here to Achilles tendon lengthening here, which would be traditionally indicated for a gastroc soleus equinus, doing that silver skull test. And realizing that the person has perhaps less than 10 degrees of extension or dorsiflexion of the foot to the leg with the knee extended, percutaneous type, hoax type approach here on a cadaveric specimen, or open Achilles tendon lengthening, and then the variety of gastrocnemius recessions. They're being done all over the world at different levels, from the proximal muscle head just distal to the popliteal fossa, right down to Strayer and Vulpius type approaches, where it's basically transverse cuts through the aponeurosis, superficial to the soleal muscle. My one take-home little pearl here, which you'll see in the subsequent slide, is that I like to do this at the end of the procedure when multiple procedures have been performed. I never want to over-lengthen, and I would discourage us from overdoing gastrocnemius lengthenings or posterior muscle group lengthenings, because it really is something where I think we need to just kind of estimate and assess the best possible at the end of the procedure. There's no doubt about the influence of contracture of the posterior muscle group. And I'm talking here not about neurological conditions, but general conditions. So there's no doubt about its biomechanical effect. It changes how the midfoot functions. The effects of equinus contracture here cause midfoot breakdown. They can cause subtalar joint issues, navicular cuneiform issues. But we need to always keep in mind how these patients are functioning in the gait cycle. And I think sometimes we believe that patients are really at the knee fully extended, and really they're not. I mean, even normal can be, 0 to like 5 or 7 degrees of knee flexion, both at the contact period and even at the very terminal stance period, right at toe off here, where the metatarsal phalangeal joints are now going into that third rocker. Many patients, almost all patients, will have some degree of flexion of the knee. So I think we need to be careful about overdoing Achilles tendon and gastrocnemius lengthenings without really assessing what each patient's need is. What we're really talking about here is this Achilles calcaneal plantar fascial chain. And weakening it at any level can seriously alter the mechanics of how the foot and ankle function. So we have to be wary and always cognizant that the Achilles connects to the heel, connects to the plantar fascia, and right into the windlass mechanism and all of medial arch mechanics and foot function. So equinus contracture, my points of encouragement are that less can be more. Less can be more. Yes, we need to assess. Yes, we need to lengthen, but less can be more. I think it's better to undercook it than overcook it. I think it's always wise. I picked this up from a talk by Dr. John Grady from Chicago. I thought it was a wonderful point, and I like the way he put it. And I try to give credit where I can remember credit is due. And he termed it correlation does not equal causation. And so it's kind of like, well, is the equinus causing the foot problem, or is the foot problem causing a gastroc soleus or posterior muscle contraction? And I think it's a very, very, very important point. And there's not even a lot of uniformity on the definition of equinus around the world. How many degrees of dorsiflexion? In what position of the midfoot or the subtalar joint? And how is it being measured? Visually, or with a tractograph, or with a against the wall type test? And so there's a lot of kind of question marks around the amount of lengthenings that should be being done in my head. And I just want to encourage us all to keep thinking about that. I also, as I already said, like to lengthen and do any lengthenings after I've completed other procedures. So for me, particularly with all adults, it's the last procedure I do during a surgery. It's not the first procedure. I would discourage lengthening the gastrocnemius or addressing a gastrocnemius equinus in competitive athletes. Many competitive athletes can become non-competitive pretty quickly if they lose muscle tendon strength after a gastroc recession, even though we may feel that that contracture is part of their problem. I would discourage lengthening or doing gastrocnemius lengthenings in competitive athletes. I also discourage strongly lengthening them in cavus feet. There can be a tendency sometimes with these cavus feet to feel like the patient is just so tight posteriorly. Boy, if I could just lengthen the Achilles or get some more dorsiflexion, they'd be fine. Long term, they're not fine. They get the deep posterior muscle compartment taking over, and they get claw toe contractures and compensations because really their cavus foot never really had an equinus of the foot to the leg relationship, back to biomechanics. And I've always already talked about the over lengthening. I'll just wrap up here with complications. In this case here, we need to be careful. If it's just kind of begging for problems. We have these sutures here that are all prominent. It's been a lot of dissection on the anterior portion of the tendon, and so the peritonon's been disrupted here. And this is just asking kind of for a wound problem down the road. And I credit Dr. Barp here for these slides on this side. And this is non-absorbable sutures that started spitting out, and later on, went on to kind of hypertrophic scarring here in the back. And I think it's just very, very worthwhile to always consider exactly these no-touch techniques in the suture choice. This is an internet photo, which I've had a few of these myself over the years. I just don't have the pictures. I guess I'm afraid to take the pictures of my own because I just feel bad for the patient, and I just can't see myself, asking them if I could take a picture of their complication. But these can really be a problem, and you can end up with plastic surgery consults and wound care consults, and everybody trying to figure out to cover this area. And I'd just like to show this slide that Dr. Bernhard de Vos Bevernage in Belgium presented at a meeting in Poland 2 years ago. I was just fascinated by it. He described a case to me where he had actually excised the Achilles tendon completely in a patient because of an infection, trying to get the area closed. In a year post-op, this was an MRI post-op of a year, where actually the entire tendon had regenerated. And I just thought it was fascinating. I'd never seen that MRI or picture before in my life. And then lo and behold, the results of Achilles tendon excision for purposes of wound closure out of Singapore was just published here, showing just a small series of patients, but all were able to heal, rise again post-operatively down the road, several years, 4 or 5 years down the road after complete excision of the Achilles tendon, because the deep posterior muscle compartment was taking over that propulsive effect, and actually has been shown to even hypertrophy on MRIs down the road. So I'll just end here with this. I'm sorry for the glitch at the beginning of the talk, and so maybe going a little longer here, but I wanted to give a very comprehensive overview of everything I could think of with Achilles tendons. And so the tips and pearls for the complications is, with anything, try to manage them before they happen, and try to anticipate it with all the stuff that we've covered with the suture selection, no-touch techniques, and everything in general. I already mentioned DVT prophylaxis for neglected ruptures. I can't stress that enough. And act definitively. Those cases where one suture spits, in general, it's better to go ahead and take them all out. If we just pick one suture out that's starting to spit in the back of the leg, and then we think we're taking care of the problem, well, then again, what happens is a few weeks later, another suture spits. So it's really wise to act definitively with these complications on the back of the leg, consult plastics and wound care centers early to try to kind of get everybody on board for what's going to be necessary. And I discourage non-absorbable sutures and watch and wait approaches to complications on the back of the leg. I think burying our heads in the sand, which we're all guilty of on occasion because we get kind of emotionally involved with our cases, and especially if we have our own complication. But it's really better to act definitively here on these cases and try to solve everything as efficaciously as possible rather than watch and wait and kind of bury our heads in the sand on these. Okay, so thank you very much. And I hope there was a nice comprehensive kind of pictorial essay for you on everything with Achilles, and I'll hand back over to Dr. Nassif.
Hey, Luke, it's Mike. Thanks so much for that presentation. I'd like to just jump in and commend you on a nice recovery there after some technical difficulties. So,
thank you. I was sweating. I apologize. And no matter how much we rehearsed, for some reason, I didn't want to go at showtime.
No, fantastic presentation. And I think, like you said, a comprehensive overview of the entire Achilles sort of attack portfolio. I'd like to kick it off with a quick question to both of you, and I'll start with you, Luke. I've obviously been attending and watching many lectures over the last several years with regards to Achilles. What has dramatically changed for you in the treatment of Achilles tendinopathy in the last, say, 15 years?
Do you want to start, Nassif?
Absolutely. Can you turn on your camera also?
Okay, going now. Should be back on there. Okay.
Perfect.
Yeah, so I see a lot of questions coming through. So, Nassif, yeah, we can start with you. I mean, over the last 15 years, what has dramatically changed for you in treatment?
Okay. I thought, Luke, you wanted to go first. Go ahead.
Oh, sure. So for me, over the last 15 years, I would say basically getting away from these big, long incisions where possible and getting into the more minimally invasive type approaches. And that's just the surgery. I think the non-operative management with physical therapy protocols and trying to really understand the biomechanics of where a patient is getting their problem, for me, has really moved along. 15 years ago, I might have been more inclined to just kind of stick a patient in a cast and say, let's get this to quiet down. But I don't do that anymore, and maybe it's my own age as well that's paralleled, my clinical experience. But I'd say in a summary, Mike, no immobilization, minimally invasive or less invasive approaches, and very protocolized active rehabilitation type protocols, regardless of what's being done, whether it's non-operative or operative.
Thank you. Yeah, and over to you, Nassif.
Luke, you basically answered what I was about to say. But if I were to break it down, my evolution, if I may say so, in acute ruptures, I have more swayed towards operative. I know this is a little bit against recent literature, but I do second your opinion that if I would go conservative, it would definitely be the functional rehab method as opposed to the operative. But I find myself with a lower threshold now for treating acute cases operatively. We now have these fantastic percutaneous, the PARs, and I'm a very large advocate of endoscopic methods, and so the acute for me has gone into the percutaneous or the endoscopic. Now the insertional is exactly the opposite. I started out maybe 15 years ago very enthusiastic with insertional Achilles tendinopathies and treating them endoscopically, removing the burr, removing the bursa, and not really touching the tendon or trying to touch the tendon with a scope. And I have shifted back to opening them. And I think it's also because of I'm getting more aggressive because of the tools I have now. I can use a speed bridge, I can use a double row suture fixation for the insertional Achilles, and I feel much more better attacking the pathology I can see, provided that they have finished off with they have exhausted all non-operative methods. If I talk about chronic Achilles or chronic re-ruptures, I find myself shifting more and more. My go-to is more and more the FHL. But as you said, you have to have the FHL transfer. You have to have more than one in your armamentarium. You have to have more than one procedure. It's not just one size fits all. But I find myself, it's a great bailout. It helps me a lot in both the chronic Achilles re-ruptures or the chronic gapping of the Achilles. So
thank you.
Yeah.
Nassif, I see that there were some questions coming in during the presentation.
Yes.
You've got some there for us?
Yes. There was a great question, actually. It was about, I'll shoot this over to you, Luke. Do you use ultrasound or MRI for that reason to gauge your Achilles tendon rupture gaps? And that might somehow sway you into going operative or non-operative. And the person who asked this, he actually specifically stated a 2 centimeter gap.
So I do think that if you have that capability in the clinic to go ahead, even with a handheld device or a mobile device, to go ahead and assess that, absolutely, why not? Because I must say that I believe that the mini open and percutaneous techniques for the active patients, I just believe give a better kind of capture of the musculotendinous unit, decrease the chance of any risk of lengthening too much length on the healing of the tendon. But if someone is just really a big fan and has had good success with completely non-operative measurement or management for most, but wants to consider mini open techniques in some, depending on patient subsets or patient-specific demands, then absolutely. The ultrasound's a wonderful way to kind of estimate how much gap there is. And if the gap is into the 4 or 5 millimeter range, the literature would suggest, I think, that a 5 millimeter gap, really those patients would do better with a mini open or a percutaneous technique than a non-operative management. But if that gap is less than 2 centimeters, or let's just say, based on that literature, less than 5, well, maybe the non-operative with the active rehabilitation protocol very carefully followed would give an equal functional result. So I think ultrasound imaging is wonderful. I don't think it requires the MRI. I don't think you really need to get an MRI on all these, particularly if you have the ultrasound. I think the dynamic exam component of what ultrasound gives you is really valuable versus MRI.
I think I'll just follow up on that. You see, more and more I've been using this Achilles tendon resting angle to gauge my patients post-operatively and see how good the tendon is resting. As you said, the most important thing that the patient would lose is that length, and that would make him consequently lose that push-off. And I have noticed that there's a discrepancy between patients with that Achilles tendon resting angle. So the normal side is different from individuals across who I've been treating for their other acute rupture. And that has kind of discouraged me from using the ultrasound, which is not readily available where I come from, or just gauging the gap on the MRI. Because it differs. It's the gastrocnemius muscle bulk, the site of the rupture, the presentation of the patient, the position that there's so many variables, the position of the ankle when you're examining and looking for that rupture or that gap. And for me, I just need them to get back to function as quickly as possible. And I think that's why I kind of go to the rule of thumb. If my thumb can fall into the gap clinically, and I know this is just being arbitrary, but that patient has already gapped enough that he warrants a surgical, not a controlled physiotherapy. I know it might sound very primitive, but it has worked fine, at least for me, and there is some logic behind it.
Very good. I have a follow-up question for you, Nassif, if you don't mind. So, unless Mike, you okay? Do you have some more questions? Because, of course, we'd like to hear from the audience first.
No, go ahead for now, Luke.
Okay. So, Nassif, I'm just intrigued with your endoscopic flexor hallucis longus transfer in the acute setting. Yeah. And then in general, as I tried to allude to throughout my lecture. So what do you think about two questions specifically? Number one, the insertion point of the endoscopic transfer, which I understand, pretty much is on the dorsal side of the bone. And I'm just wondering, is there any way you could get it, or do you believe it would be worthwhile trying to get it down more immediately? I mean, the Achilles really is in the frontal plane. The moment arm of the Achilles is an inverter as well as a plantar flexor. So I'm just wondering if we could get the FHL transfer as immediately as possible, like the case I shared of my colleague from Rhode Island, Dr. Caldarella. I wonder about that. And then the second thing I wonder about is, what do you think about the vascularity of the muscle belly? Is that really something? I mean, does that help if we can get that muscle belly kind of sewn into the undersurface of the Achilles tendon, or is that just not really matter? Is that, because I don't really see that being done or possible with the endoscopic approach. So insertion point and the value of the muscle belly being anastomosed to the anterior side of the Achilles. I'd love to hear your thoughts on that.
Obviously, these are two great questions. I did have a discussion kind of format planned out, and I was going to pull out the kind of presentation and go through that. But I'll answer you right now, just shortly, prematurely, and then maybe we can go on to that informal kind of discussion presentation now.
Okay.
Now,
sure.
As regards the insertion point of the FHL, remember, you are rerouting that to try and mimic the functionless at that moment Achilles tendon. So it will differ according to the pathology that I'm treating. I know now I am trying to use them more and more. I've been for the past 5 years, me and Jorge Batista and Helder Pereira from Portugal, and we have been doing this right now, and we've just recently published it. But in the acute setting, we are trying to get that FHL as close to the Achilles as possible. We're trying to get the best of both worlds, if you will. We want to have a patient mobilized immediately. We want to have them have that internal strut and that biological healing of the low-lying muscle. So in these particular patients, we insert the FHL exactly where the previous insertion, in the middle of the previous insertion of the Achilles. We actually have to do a kind of arthroscopic endoscopic Hageland's removal, bursectomy, to insert it. Now, if I am using the FHL for a chronic case, I would want more of that medial pull, more of that inverter. And then I would be more prone to shift the insertion point of the FHL more medially, as you said. That way, because that patient is chronic, he has a lot of fibrosis, we're talking about FHL transfer, so that's more than 3 or 5 centimeters of a gap already. He's probably been a year or two down the line. He's not been mobilized properly. His gaits are all messed up. His gait cycle, biomechanics is all messed up. And that's why I would want to give him the best possible result by possibly moving it onto the medial side more. Okay. So I hope was that you?
That's a very thorough answer. I appreciate that. That's clarified exactly what I was wondering about with the insertion point.
Yeah.
Do you ever suture? Can you endoscopically suture the muscle belly into the Achilles tendon, or do you not really think that's necessary?
No, in the first cases, this was like I said 5 years ago. We started by just putting using a mini scorpion and just attaching the part of the tendon to the Achilles rupture, hoping that we will kind of get the muscle belly more closer. And then we simply abandoned it, and it was only for a few cases, I think 3 or 4 cases. It was cumbersome, as you said. We didn't think it would add any value, and we have never touched the Achilles from that point down the line. And you'll be amazed at I'll show some of the MRIs of these patients and their physical performance. So let me just pull up the screen, if you don't mind. Mike, can I start with the discussion? It's going to also answer some of the questions here.
Sure.
Okay.
Let's go ahead. Thanks, Nassif.
No, my pleasure. Okay, so as we said, guys, we're going to start case discussions, and this is I think what most of us would like to learn about, or to see how different people do it. So let's start with this case. Let's say it's an acute Achilles mid-substance rupture, and there's no previous degeneration. And let's say it's a 45-year-old weekend warrior, and the injury was fairly recent. It's 5 days ago. So would we go conservative or operative, Luke?
So I believe the PARS mid-substance speed bridge type approach is really ideal for that patient. And I understand that worldwide there's many regions that are treating these conservatively, but I just think if we can kind of get that musculotendinous unit back down to length under some sort of physiological tension right out of the gates, and with these advanced rehabilitation protocols, I would go mini open or percutaneous type of approach with that personally.
Okay, so let's just say that if we are going to go conservative, you have fully pointed out that you would not cast that patient. And if you would only cast them for like 2 weeks, and then you would progressively shift them onto functional rehabilitation, right?
Absolutely. And I would just stress again, and I guess I'm aware from something you said the other day, but also in my travels, that some folks will just stick some of these patients with the conservative management into a short leg cast for 6 weeks and leave them be. And I just really think that's really counter current to what we can be achieving nowadays. So maximum 2 weeks to let things kind of quiet down in a plantar flex cast, and then out of that cast into boots and onto functional rehab.
This was a question from the participants. Is there any role for PRP or this new ACP Tendo?
Right. So I have to plead don't know on that one. My experience, honestly, and I'm not one to invent things that I am not really sure of, or seasoned in or familiar. My experience with PRP comes from clinical practice, predominantly in the United States, and I could never convince myself, first of all, wasn't covered by insurance, and that became a big issue. So patients would have to pay out of pocket, and it wasn't cheap. And then second of all, is I could never convince myself that and this could be Achilles, this could be like supplemental therapy or as an adjunct, and it could even be for plantar fasciitis for chronic patients trying to avoid operative management. I could never convince myself that all the variables were sufficiently controlled in all the different studies to really be able to say that it was working. I mean, does the patient walk out in a boot? Does the patient walk out right away? What was the most recent use of anti-inflammatories? Did you mix local anesthetic with an injection? I'm sorry, a steroid with the injection? There's so many variables. Yeah. So I'm the guy to have a solid opinion to help somebody on that with.
Yeah. You're exactly right, because I think the most recent systematic review, it showed that there's a very low evidence in favor. It's a grade A, actually, in favor of PRP. So you cannot say that it would differ. Also a question from the audience about the functional rehab. Now, let's say that this is a more senior individual, he's a more elder individual, and has some comorbidities. Would you change your rehab, your rehab format in any way for these older patients?
I would be completely comfortable in what you just described with treating them non-operatively, and I have in the past and over the years. And as far as modifying the post-rupture management, not particularly. I mean, I might, after taking that cast off, because I already told you my maximum would be 2 weeks, I might have them put that boot on. Under very strict control. I mean, sometimes I'll put people in a boot and tell them, don't take it off. It's just like the cast. But I'll let them take it off to do some range of motion while they're watching TV, things like that. I mean, I might I might be more conservative or cautious between 2 weeks to 6 weeks with that patient.
Yeah.
But if you added up all the real kind of like bullet points or your checkoff list of, let's say, like the physical therapists do, where they have to kind of, tick the boxes of whether the patient is meeting the progress points. I don't think if you looked back at that patient after 4 months that I would have very much different as far as ticking off those boxes, but I might adjust the phases a little bit, particularly between 2 to 6 weeks.
And definitely DVT prophylaxis, of course.
I'm big on that. And I know the literature is not really too chunky on that, but
Yeah. Okay, so we agreed you would go percutaneous. There was also a question here. What type of sutures would you prefer? Yeah.
Well, as I said, I'd like to retire Ethibond suture now. I don't have any stocks that no longer make any money on Ethibond suture or anything like that. I'm just joking, but lower gauge, 2.0 fiber wire suture tape. For peritoneum, for example, 3.0 or 4.0 monocryl, or let's just say, I don't know if everyone has the same names, but in my world, it's been monocryl and biosim. But let's just say monofilament absorbable sutures of, let's say, the peritoneum, a 3.0 or a 4.0. Let's say deep fascia or sub-Q or skin, a 4.0 or a 5.0. Monofilament, least reactive, and anytime. I'll share one thing with you. I had, when PARS first came out, I had a meltdown of my own where I'd done the PARS proximally and the PARS distally. And of course, it was the physical therapist brother or brother-in-law, I think he was, who I refer, he was the physical therapist I used for all my patients, had a wonderful relationship. And of course, it was this patient, like it always is. But anyway, it broke down because of all the knots. Now, maybe that's my fault. I didn't necessarily bury the knots or leave all the knots internally enough or deep enough or something, but I don't want heavy knots. I don't want non-absorbable suture, and I don't want it at the rupture site. And I don't want it at any incision site, even if it's a mini open incision.
Okay, yeah, great. Okay, so when would you tell these patients that they would be able to return to play? Would you wait for MRI? Would you clinically? Is there a certain borderline where you say, okay, you're great, you can go back to your normal physical activity?
Well, I would not consider it at all, personally, shy of 4 months, quite frankly. And then if physical therapy, if the physical therapy center had the ability to do some testing between one side to the other, such as like Cybex testing, and I'm sure there's something, perhaps a newer generation that I'm not aware of because it's not my area of discipline or expertise. If they have an ability to grade what percentage of recuperation of the gastroc soleus and even the quadriceps and hamstrings and so forth on the injured side, where they're at versus the other side, then I would want to know that. And then certain patients, of course, will just do much better faster than you thought. But I'm always hedging my bets and trying to be conservative in that regard. But I would say minimum 4 months, absolute minimum, and then trying to get some objective data from physical therapy about how they compare to the uninjured side.
So this was a 45-year-old. If it were a 23-year-old athlete, would that change your decision? Would you still go percutaneous?
Yeah, I would do yes,
even
I would.
More? Yeah.
I would do pars proximally and the Achilles speed bridge distally.
Now, if the injury was not 5 days ago, but it was 2 weeks down the line, and we do see these patients, they pop their Achilles, they walk around, and then until they do get diagnosed a little bit later on, even if it's a 20-year-old or a 45-year-old. So it's 2 weeks. Would you still think you could mobilize the tendon percutaneously?
So I would still have the original approach, but into my tips and pearls section of my lecture, that's where I would have plan B, and I would have no hesitance to open that up intraoperatively and make a little L-typed incision or a lazy S incision or extend.
So you would still use the transverse incision as originally described with the pars, or would you, in that particular case, just slightly make it longitudinal in case you need to extend it?
I would start transverse and then be completely happy to extend it very promptly. But, even 15 days, I don't think necessarily 15 days is that long. When you get into 3, 4, 5 weeks, I think that's different. But 1 to 2 weeks, depending on how that patient's been managed from the day of injury to that 15-day mark, it could be variable. I would start with the per-Q and be ready to open it if necessary.
So would it be any difference if it's a 57-year-old, 60-year-old?
Well, if they
physiotherapy?
No, if that 57-year-old was only 5 days ago and I had decided based on their own desires, I just saw this skin adherent due to previous burn injury.
Yeah, well, that's a special condition, and there's a story behind this, of course. So I had this guy, he was 57, 58, and he had this previous burn injury, and he had an Achilles injury, and we didn't have that functional. He didn't want to adhere. I'll show you why in a while. And so what would your options be? Would you still go the percutaneous way? Would you, any other difference?
Well, I'm gonna beg off on that one. I would probably treat that person personally, non-operatively, although with your skill set with the endoscopic FHL transfer, that might be a wonderful application of that this patient. But I would not be opening that. Just looking at the back of that guy's leg, if that's the actual patient, I would treat that non-operatively. And
that was the guy that stemmed this idea of this endoscopic, or those that come with a tattoo, these guys that say, don't you dare touch my tattoo, doctor. You're not going anywhere near it. I ruptured my Achilles. Yeah, I don't care. You're not touching my tattoo. And that's what made us decide in this FHL. We'd used it so much for the chronic cases, and we were amazed at the results. And that was the patient that we started with 5 years ago. And it's a pretty easy procedure if you have your endoscopic skill set with you. And then we started using them on acute Achilles ruptures. Now, as I said, we just recently published this, and it's just still in corrected proof right now. And I just want to show you, these are actually our MRIs of these patients. Now, in reference to your question about the insertion of these insertion point, we try to make them as far, these are 6 different cases. We had a series of, I think there were 56. We tried to take them as far posterior, and we tried to get that FHL as far close enough to the Achilles. Now, these are all post-operative. They're a minimum of 12 months post-operative. So these were all ruptured and separated Achilles tendons. And this was just a combination of these patients. And I'll show you now, this was the case, the actual case we started off with. You see there, it was 2017. This was one of the cases, that we had on the first slide. This was the pre-op. This was 1 week, and you might ask, why do we do the 1 week post-op? We just want to know that we have the screw where it should be as far posterior as we can to the actual insertion of the Achilles, and we want to know that in the sagittal plane, that muscle belly is lying right close to that Achilles tendon rupture, as you can see. And this patient, this particular patient, we had the 18-month post-op, and you can see, look at how much that Achilles has regenerated. So.
Yeah, that's really impressive.
So this is from pre-op to 1 week post-op to 18 months post-op. And we've done these on quite a number of cases. As I said, we started out with older guys, people who had skin adherence. Now, this is a patient, this is credited from Jorge Batista. He's one of the main proponents of this technique. And this is an actual football player. Now, of course, this is a professional league. Jorge treats the Boca Juniors, so these are the first division people. And
oh, wow.
Yeah, and this is the guy. Look at the sprint there. He had an Achilles done, FHL, 9 months prior to this particular game. So that's wow. That's a high professional athlete, and you can't hide these guys. You can't tell lies with these guys. If they're not good, they're not good, and they make your life miserable. So we started off with the older patients, the patients that had these skin problems, and we then started shifting to those who would be elected to be treated non-operatively as opposed to non-operatively, for sake of time, obviously. And we use this technique. And you might say, okay, so these guys are only good enough to make assists. Well, no, they can also get the goals themselves. In this case, this was also another guy. This is I use Jorge Batista's videos. He has much nicer videos than mine. Mine are always shot with the home cellular phones. I don't know why. Maybe I'm not so famous with the players. Anyway, so this is the guy. Of course, we have his full consent. He had an endoscopic FHL for an acute Achilles. I think this was eight months prior to this particular game. So in summary for the acute, I also love this article by the JBJS in 2015. They had a kind of algorithm for how to approach Achilles tendon in general. Let's just focus on the acute Achilles rupture. So they went, if it's an acute case versus a chronic, you would either do the functional bracing, as we said, or a direct repair. And they actually state plus or minus an augmentation, of course, if there's a gap. Now, I believe that FHL gives you both biology and functionality, because then you can get the best of doing the operation. You can also use the percutaneous techniques, and we're actually now doing an RCT with percutaneous techniques for both these types of ruptures. Just a word of caution, as you said, because particularly where I come from and in our parts of the region, we tend up not saying we're treating the patients conservatively, but we actually not, because functional rehabilitation entails a whole schedule. You start from day 0 and you keep going, look at that, up until 1 year. And this actual paper, if you look closely here, at 4 months, that's 16 weeks, they actually state there that you should ensure that your patient understands that the tendon at 4 months is still very vulnerable. And yeah, and so they're going really slow. So if you put that into context, if you offer a patient with an acute Achilles a functional rehab, but you tell them you're probably not going to be back to your activities before 4 months, not soccer, not sports, before 4 months. And if you put on the other side a percutaneous, a PARS technique, or an endoscopic FHL, and you can have them playing actually the game at a high level at 6 or 9 months, then I think there is a value for this. So if there's a question here for acute open mid-substance injuries. I think, Moaz, we just covered that. We would either do the PARS, that's the question from the audience, or in my case, I would like to do these acutely, the endoscopic FHL. So if there are no other questions, we can move on to chronic Achilles insertional tendinopathies. Now, I like the part you pointed out, Luke, wonderfully, because in insertional tendinopathy, eccentric exercises are really not good. And there's a recent systematic review that has just shown that. But on the other hand, Eswit therapy does fine. Do you have any particular preference for the Eswit therapy? And how long would you keep that going?
For chronic insertional, so
yes.
Absolutely.
The extracorporeal shockwave.
Right. So, I literally try to look at every patient as if it was their problem, as if it was my own heel. Yeah. And I would absolutely exhaust. If I had chronic Achilles insertional tendinopathy, I would absolutely exhaust non-operative management, shockwave therapy. I would try modifications of shoe gear. I would try night splinting. I would try all the physical therapy modalities. There were a minimum of 3 months. I would. And then between 3 to 6 months, I would soldier on personally, non-operatively, as long as I was seeing even percentages in the 10 to 15% of improvement every fortnight or every 2 weeks or so. Yeah. And now what I tell my patients is, look, minimum 6. I always tell them physical therapy, absolute minimum of 6 weeks. If you can't commit to 6 weeks, then you're just not giving it a fair shake. I say 6 weeks minimum, 12 weeks maximum, but not necessarily. Let's see how you're doing. Yeah. And at that 12 weeks, which is 3 months, and I continue on. But let's say over 6 months of failure of physical therapy and non-operative management, then I'm talking to them about surgery. But there's one other point I'd like to make here, and that is when you get these patients that they get frustrated, because they all do. They all get frustrated, and they come to you, and perhaps you're the second or third provider that's seen them. So the question is, well, how much physical therapy have you had, and what are your parameters as the now treating physician? Well, just because they say, well, I've already done all that, doc, I don't really accept that personally. Mm-hmm. They need to initiate it again with me so that I can be sure that I'm exhausting that. Because the reality with these patients when you operate on them is that if they're doing 75 to 80% wonderfully well by 1 year down the road, I consider that a really great result, because I want to be sure I can optimize the result as much as possible.
And specifically regarding the shockwave therapy, I personally tend to advise them for the radial type, the radial low frequency. I know there's a lot of literature out there. You can have the high frequency, which of course entails a lot more pain, and you can have the focus type of shockwave. But I think, and this is also for my part of the world, you need to be in touch with your physiotherapist or with the person who's going to be doing the treatment for them, and you really have to talk to them and converse with them that which type of treatment they usually get. Because after all, even Eswit therapy, they're usually around 3 or 5 sessions at the most. So you need to make the best of them. So if you're going operative, what type would you, what would you do? Open? Would you do an augmentation? Again, would you use an adjuvant or a PRP?
Right. So when I treat those open, I do a full debridement of the calcific insertional tendinosis. And then if the Achilles tendon, and it's just a rough, kind of subjective, but if it's over 50%, involved or degenerated, mucoid degeneration, intrasubstance tearing, and just of poor quality, then I'm going to do an FHL transfer.
You see, Luke, that's why I love you so much. You see, you anticipated the question there. So I was going to ask you, and this is really clinical. This is what we guys do down in our clinic. Now, is it clinically the site of the main tenderness? Would that affect your incision in any way? If there's a posterior spur as opposed to a calcification in the tendon, would that affect your decision, operative or non-operative, and where you would place your incision? And as you just said right now, the MRI and the size of the degeneration, the percentage of the initial tendon, would that affect the decision? So you go first, and I'll tell my comments after that.
Okay, so that's a great question. And so now, in general, my preference is to keep the incisions medially, or medial with a L shape on the bottom to get over laterally. However,
I was just about to ask you about that. Sorry to interrupt you, because in your presentation, you said that the main blood supply comes from medial.
Correct.
And yet, most surgeons I know of, they would rather attack this medially, arbitrarily, or centrally, if they do not have this preference of the site of main tenderness or where the main enthesopathy is. What's your comment on that?
Did you say that most will prefer to make the incision laterally?
No, medially. I said medially.
Right, I prefer medially, and I prefer medially because I can extend it proximally, and I'm closer to FHL, but also because all the vascularity is medially. I think it's less chance of a wound problem. And then as far as getting laterally, you can get laterally. If you make it medially, but it's like an L, then or a hockey stick incision, we sometimes call it, it basically opens up like a flap, and you rotate it up, and you can get all the way over to the lateral side. So I still prefer medially. However,
yes.
If when I do that little grid, I draw that little grid on the back of their heel, if they have zero pain medially, and their pain is like pinpoint on those little tic-tac-toe board, that grid just laterally, I'll actually do the incision laterally.
Okay, so there's no need for me to put my 2 cents in, because that's exactly the way I would do it. I would start off medially, except if their exquisite pain is on the lateral side. Now, if there's a spur, you know, these lines, the parallel pitch lines, the Fowler-Phillip angles.
Yeah, sure.
Do you use them practically in your operative setup or in your approach to these patients?
No, honestly, I don't. I'm well familiar with them, and we've learned them all. And I suppose maybe I, passed a few exam questions on the Fowler-Phillips and the parallel pitch lines and so forth.
But they don't necessarily equate to practicality. You don't use them. I
don't use those.
It's the same for me.
Honestly.
Is it the same with the calcification, where you have these little calcifications inside the tendon, intratendinous? Would that differ in your approach to these insertional Achilles tendinopathies?
Well, I definitely end up debriding them. I take a number 11 blade and I kind of, pick them out and so forth. And seeing them intraoperatively, because they're usually more apparent, or there's more of them intraoperatively than you can pick up on imaging preoperatively. Those patients end up routinely getting an FHL transfer.
Okay. And last one would be the percentage of degeneration on the tendon. Do you still stick by the 50% rule, that if it's less than 50%, then you don't necessarily need to touch the tendon? If it's more than, then you would need to touch the tendon?
Yes, I do. I do stick with that, but I'm well aware that there's been some studies in the literature that say that the functional outcomes are really basically the same whether you use an FHL transfer or not. I've seen a few articles saying that. However, back to one of the comments I made in my talk is I'm always asking myself, with foot and ankle pathology that we end up operating on, how can we leave this better, stronger, less susceptible to recur, more reinforced, some way better than simply what we found? And so I will tend more to that FHL than not.
Yes, and I think that also answered the question about the number of the sutures and the rows, this double row, this speed bridge technique, where you have disinserted the tendon. That would definitely give you that ability to reinsert the tendon back where it should be and have that reinforcement that you can actually mobilize these patients to heal better with mobilization as opposed to immobilization, right?
Yes, exactly. I think the double row allows you to advance the rehab and decrease cast disease.
Okay, so if I am debriding a tendon and I've removed almost 50% of it due to removing the calcification and the degenerations, I routinely do an FHL at the same time. Is that the same for you, Luke?
Yes, exactly.
All right. Now, you see, this is where, when Mark talked to us about, asked us both where we've changed. Now, this is a paper, it makes me feel so much old now, that I started working on with Jarosch in Germany in 2003.
Remember, you're only as old as you are.
Yeah, okay. And I was treating these people. There was this research of the arthroscopy. I was doing this endoscopic calcaneoplasty. It was a big thing at the time. And we were not even touching the tendon. We were just doing this endoscopic calcaneoplasty, removing the bone, removing the bursa, albeit endoscopic. endoscopically, and we were quite happy with our results. But then the curve started to come back again. And then I switched again, as I said, from doing them endoscopically to open and doing this hockey stick. There you see the hockey stick incision from medial to lateral. And I do, just a little tip here, I keep that, you know, the expansions of the tendon. I keep the lateral expansion, if the patient doesn't have a lateral exostosis, I keep it inserted, and that's what I gauge my tension on when I am reinserting the medial and the central part. So I do not doggy ear it, neither do I stretch it. I just return it back to its tension, added, of course, with a double row suture, of course, the speed ridge. So I've actually transitioned from this endoscopic calcaneoplasty to this now. Funnily enough, I just looked back at literature, and this was a current concepts review update in the FAI in 2017 by Fitzgerald and co. from Iowa. And they actually, when they were talking about the endoscopic minimally invasive, they said that no additional studies had been published. They actually quoted our study and Leitz's study in 2003 ever since, because I think the scientists and doctors have fallen back off this endoscopic. So insertional, I think, is there. So if there are no more questions for the insertional, we can quickly move on to the non-insertional. And the point you made about eccentric training, it works wonders for the non-insertional as opposed to the insertional. Am I correct?
Yeah. I mean, I think it was born from that application, actually, really.
Yeah. So would you also adhere with the 3 to 6 month?
Yes, definitely. I mean, this patient base who gets this problem, these are athletic people, and they want to get back to what they're doing. And if they're, I do want to see them hitting progress points. They've got to be kind of improving. So I will continue for that minimum 6 to 12 weeks, and then if they're improving, I'm going to tell them to continue on. And again, I believe the actual recommendation, I'd have to confirm that, but I believe it's like 6 sets a day, a minimum of 15 reps each. And so, that's a bunch of sets a day for people to put into their time, but the most committed people will do it.
Yes. Also a question here, because I've seen this, I've been traveling around the world, and I've seen that there's a sort of endemic proportion. So in your part of the world now, you've seen both parts of this globe. You've seen the States, and you've also seen Spain. How would you compare the numbers of insertional, arbitrarily, of course, to non-insertional? So which is more common?
I see, and I've always seen more insertional in the United States. And I directly relate to obesity, quite frankly.
Well, okay, then we're also an obese population, because in our parts of the Middle East, we also see a lot of insertional as opposed to non-insertional. I hear in the Asian states, it's actually the opposite, and possibly also in the Caucasian states in Australia, Asia. Okay, so would you treat these different, open? Would you also augment them? Would you still use any adjuvants?
Right. So in my practice in Arizona, one of my partners was very much into and using and really on the head of the learning curve, and even teaching on the, it was called 10X. I guess it's ultrasonic micro debridement of just the pathological tendon. I do think that has an absolute role in this type of situation, where the ultrasound actually allows differentiation of healthy tendon and degenerated tendon, and it actually will only, because healthy tendon fibers are more, let's just say, resilient, that you are selectively debriding the intratendinous degeneration. And then the work of Amal Saxena, who's a good friend of mine, I really trust his publications and his clinical experience. I think these minimal approaches, where you're debriding minimal and debulking if necessary, are really worth trying versus the big approaches and the FHL augmentation. But it's a case by case thing. Again, PRP I don't have experience with, but I can't see how it can hurt. I think it's worth a try. I don't see any downside to it.
Yeah. Yeah, and that's why when we do the FHL, we think, because we're drilling a hole in the calcaneus, that we're actually getting out these growth factors and PRPs out in a way into. So yeah, we're trying to push the technique any way we can. No, seriously. Anyway, so in conclusion, because I do not see much more questions coming in, I really like this article I alluded to earlier. It shows everything Achilles, and as I said, it shows the Achilles tendinopathy and the Achilles rupture. We've seen the rupture part. So in Achilles tendinopathy, it kind of this algorithm is brought out in if you have the bursa or the insertion or non-insertion, of course, and once and twice and three times, as Luke says, you have to go conservative. If that fails after the 3 to 6 month period, then it depends on what exactly you might have. If you have the thickened parathenium, then you excise it. If there's a spur only, you can excise the spur, which we were doing arthroscopically previously. If you have a discontinuity, you have to debride the tendon. Now, if you have a discontinuity, which is more than 50%, and you have a tendon of the tendon width with a rupture, you might do an FHL transfer. If it leaves you a 3 to 5 centimeter gap, then you have to think about augmenting it in a certain way. In our parts of the world, we don't have access to allografts, so we have to make do with what we have for these more than 5 centimeter gaps. And I think the last part of your presentation was really nice about the complications, and this is a part that everyone who deals with Achilles has to know an algorithm. And I just pulled this out. It's in 2019. It's in the FACN, the Foot and Ankle Clinics of North America. And I really like it because they describe it according to the wound breakdown, the infection, or the re-rupture. And there's this algorithm also there, which is really, really nice, according to if you have a wound breakdown or a tendon re-rupture. Let's start with the tendon re-ruptures. If you have a tendon re-rupture, you immediately assess the tendon quality. And according to the quality of the tendon, if it is able to be primarily repaired or not, you then, after what you've done with your tendon, you assess the wound. Can it be closed or not? And then you can go through if you either close it after you've assessed the tendon or you need your good friend, the plastic surgeon. Now, if at the beginning you have the wound breakdown, if it's a local wound with an exposed tendon, so wound breakdown, but the tendon is exposed, then if it can be done locally, then of course you go ahead with that. If it can't, then you need to do repeated debridements, VAC treatments, and then go down and assess tendon quality and go back down from there. So I would advise people to look at this algorithm. It's not 100% proven, but it is a guide to go by. So I think it's also nice. And these are some of the references that I thought would be pertinent, and we actually use them in our study. So at the end, ever since this Greek mythology has been centuries there, and we all know the Achilles tendon, I do not think in the 2020 we have reached a part where we can say we know exactly what to do about which pathology. And I think that's where science still has to play a role, and we still have to pan out and iron out the folds we still have with these Achilles. So thank you. I think that's it. Mike, if there are any other questions, I'll just unshare the screen there.
Thanks, Nassif, and thanks, Luke. A huge appreciation to both of you for your time and efforts today. I know we went a little bit long, but I think it was certainly worth it. I think the guys got a lot of value out of the presentation. So thank you again for your time, and I appreciate it. For anyone who's looking for these presentations, they will be available in the next upcoming days on our YouTube channel. So look out for Ortho Engage on YouTube, and then join us for our next sessions coming up next week. Glenohumeral instability and lateral ankle. So thanks so much again. Have a good evening and stay safe. Thank you.
Thank you very much, Mike, Nassif, and everybody. Thank you, John.
Always a pleasure.
Ali also.
Yeah.
Thank you, guys.
All right. Cheers.
Okay.
Take care.
Cheers. Thank you.
Cheers.
Yep. Bye-bye.
Bye.